We are honored to have with us this morning Dr. Jacques Morcos, who comes to us from the University of Miami, so he's a local guy here. He is the co-chair of the Department of Neurosurgery here at Miami. And by way of background, he did his residency at the University of Minnesota and trained additionally at the University of Florida, and then with Dr. Robert Spetzler, who many of you know and love from the many years of practice that he had at the Barrow. He came to the University of Miami when he was a child in 1995. He is highly regarded as an expert neurosurgeon for cerebrovascular and skull-based neurosurgery, both in the community here, not just both, in the community here, nationally among patients, and also nationally and internationally among other neurosurgeons in the neurosurgical community. He served in varying roles in many of the professional organizations, and next year is going to become the president of the American Association of Neurological Surgeons, which is pretty much the highest honor that you can have in the field of neurosurgery, with just a couple little exceptions. So I would like to welcome Dr. Morcos, who has a few slides to share, but really is mostly here to answer your questions. So.
Thank you. Good morning, everybody. I love those things. You know, I actually get tired of talking to my peers all the time and traveling, and you know, this is what we live for, just talking to patients. Actually, it's not operating that I enjoy most. It's actually sitting in my clinic and talking to patients before surgery, getting them to trust me and so forth. You know, it sounds cliche, but it's actually what I enjoy the most. So I'm delighted you're here. Connie, what you're doing for the last 20 years, 2003. So it's really, you know, I mean, this is unbelievable. I didn't know you before, and I read about you, and it's just remarkable. Thank you for the generous introduction. I wasn't sure how this was going to go, so I'm here to answer questions, but maybe I'll frame. I'm sure you've heard a lot of information about CavMals the last couple of days. Just a few slides, maybe to give you things to ask me about, unless you already have questions. You know what they are. Essentially, 0.5% of the population have them. Adult presentation, usually 4th to 5th decade. More than 50% of familial forms have multiple lesions. This is meant for you not to read, but to show you how much we disagree in the various published papers on how to calculate the bleeding risk. I don't want to get into the math of it, but the problem is what's called the denominator effect. When you say, well, you have 2.5% per year chance of a bleed, is that from the day you were born? We don't know at what age you developed it. Lots of statistical things that make the numbers completely confusing to physicians, let alone to patients, if you really start reading those reports. I'll tell you, I'll finish up later on by telling you what I tell patients about their risk of bleeding when they have a cavernoma in a second. I've always been interested myself, particularly with brainstem cavernomas, because they are actually obviously the hardest to decide about, and surgically definitely the hardest to take care of. Unfortunately, if you want to remember kind of a number, they hemorrhage twice as more as what's up here, the supratentorial, the cerebrum. The brainstem twice as more, and more eloquent area. If you want to remember some numbers, if you have a cavernoma in general that has never hemorrhaged, it's between 0.3 and 1% per year of a chance. I tell patients 0.5% per year possibility of a hemorrhage. If it's hemorrhaged already, then you have 2.5% more chance that per year that it will hemorrhage. If it's in the brainstem, it's higher. It's between 4 and 5%. So the numbers to remember or to 0.5, then 2.5, then about 5. That's what I tell patients when I talk to them. You know, the brain stem, these are cross sections of the brain stem. Again, those of you, I'm sure some of you are extremely knowledgeable about this because you must have read everything there is to read about it. But to show you the colors, forget the details. The colors are the important stuff that we surgeons don't want to touch. So this, you can see how dense it is. So this is what's called the midbrain, the top of the brain stem. This is a little lower. This is where most cavernomas occur, in the pons. Luckily, I say luckily, because you can see there is more bare areas, the non-colored areas. And we surgeons have these safe entry zones that we get through. Luckily, we have some entry zones and options to get through to remove some of those cavernomas. The medulla, like down here, between here and the spinal cord, very dense. Luckily, this is the least common site for brainstem cavernoma, because we don't have, except for 3 arrows, there are not too many options to get in there until the cavernoma opens up the space. And here I've summarized with these green arrows all the ways you can operate on the brainstem, and we're going to skip that. I'm going to skip that and just give you one patient story to show you it can be quite tricky. If you bear with me a second. Before we get there. Last year, I collaborated with all of these investigators from Europe, from the US. You can see Gary Steinberg here, Mike Lawton, our good friends, and so forth. You know, how do we decide? And so what was done, what's called an international Delphi consensus. This is no more than collating what experts say about what to do with brainstem cavernoma. Very complicated. Each line is a separate expert that has given. We're trying to figure out, do we agree on how to do medical decision making? And this is a summary slide. Just to give you an idea, the things we agree on and the things we possibly have controversy about. In green, we agree a lot that if somebody has multiple hemorrhages and progressive difficulty neurologically, and it's an easy surgical access, those patients should be operated on. That's the top right green box. The bottom green box is if it's a first hemorrhage with symptoms or severe deficits that is progressive, and it's causing what's called mass effect. The cavernoma is putting pressure on the tissue around it. That should be considered for surgery. The conservative approach is in the red boxes, and you can imagine what those would be. Very difficult, very risky to get to it, minimal symptoms, things like that. And then this whole gray area in between. And this is really the summary of that paper. I'll give you one patient story, and I think I'll stop and I'll sit down and I'll answer questions. So this is a 27-year-old Egyptian female. Back in 2014, she had a little droop in her face, numbness, double vision, imbalance, and she was found to have a lower brainstem, lower pontine cavernoma. She went to another excellent institution in 2015, had surgery. She had a rough course, very rough course. Face paralyzed, on a ventilator. She took a long time in rehab. And eventually she made a very decent recovery with a partial facial weakness. So what I want to show you is, so this little thing, this little cavernoma, I don't know if you can see it, the white dot here in the brainstem, does not quite reach what's called the ependymal surface. It doesn't have, it's surrounded by highly eloquent real estate. It's not a good case for surgery. I don't think she should have been operated on. back then. The surgeon should have waited till it was bigger, reaches a surface to access it more safely. So this is how she was right there, 2014, no surface representation. Unfortunately, 3 years later, it grows back because obviously a tiny piece must have been left. And she knows somebody that knows me and so forth, so she comes to me. And now she is like that in 2017, right here. And 2018, growing more. And 2019 is when she comes to me. You can see this cavernoma right here has grown. Now, the difference, it's counterintuitive. A larger lesion is easier to remove than a smaller lesion because it gives a path to itself for the surgeon to remove. So now I'm seeing her, young woman, late 20s. Now this is operable, but I called it the path least traveled. I am certainly not going to go back in through the site that was used before, because this is what got her into trouble. So you kind of go the long way around what's called the far lateral approach. And that's what I did. And I probably don't want, some of you perhaps don't like to see surgical things. So I'm not going to show it, but close your eyes. I'm going to go through one slide to go to the, here we go. Okay, this is during surgery. And this is a guidance system that tells us exactly where we are, very important. And this is, I'm not going to show you the video, but she did superbly well. I didn't give her any new deficits. Here is a cavernoma completely removed. She went back to being a very successful lawyer. Oh, by the way, I'm sure you heard a lot about DVAs, developmental venous anomalies. You see it, it's right here, this white vein that we surgeons absolutely do not want to damage, because if you do, you're damaging a whole lot of normal brain around it. So it's a matter of get the cavernoma out without damaging the DVA. Yeah, that's it. I think I'm just going to stop here and I'll answer anything.
I'm not going to stand here. I'm just going to say, as you have questions, please wait for the microphone to come to you.
Thank you very much. Is the hemorrhage rates for spinal lesions for the same as for cerebral hemorrhage?
Good question. They're the same as the brain stem, but since, as you can imagine, the volume of spinal cord is so much less than brain tissue, we have much fewer patients. But I quote the patient the same as brain stem rates. So if they've bled already, I tell them about 4 or 5% per year thereafter cumulatively.
Hi, I'm way back here. Thank you for being here and for working with Connie and doing everything you're doing for all of us. My question is about surgical techniques and if there are technologies coming to the forefront that might help with some of these risky surgeries, nanobots I'm hearing about, untethered little robots. I just wanted to know what your perspective and your experience has been.
Yeah, you may have heard Gary, my good friend Gary Steinberg earlier, maybe he presented using the laser. You know, we use the laser, when I say we, it wasn't my times, before my time. Laser were around in the 70s and 80s, and like technology, they follow a circle. Nobody used them for a while, then they discovered, oh, we might use them for this. So the laser I use the laser, for example, for fibrous tumors. Laser are useful in shrinking the cavernoma a little bit. The problem is, neurosurgery is a very small field, and industry is interested in money. So they go where the volume is. So many things should be miniaturized and robotized. Particularly, I can give you other examples. Bypass surgery. I do lots of bypass surgery. I wish there was a robot that could take my place and do these 10-0 stitches. They did it for a while in heart, but heart is like 100 times more common than what we do. So there isn't an interest from industry to miniaturize and robotize what we do. In skull base, there are robots that do now oral cancer. My colleagues right here in Miami, the head and neck surgeons, they do all oral cancers with robot assisted. We don't have much of that in neurosurgery. We should get it, but it's all about the money, unfortunately.
If a cavernoma in the brainstem was removed but not fully removed successfully, would it be more likely to bleed because it was touched and
Yeah, I understand your question. No, not really. We don't have evidence that injuring that animal will make it angrier. That's pretty much what you're asking. No, it's really, I quote the patients, like this young Egyptian lady. I told her, you have the same rate, which is about 5% per year. You're 28. The odds are stacked against you if we do the conservative approach. But no, removing, and I've done this sometimes on purpose. I mean, I never do it intentionally going in, but if during surgery the monitoring tells me I'm hurting this patient, I'm not going to remove everything. I'm going to chop it off and leave a piece because I'm forced to. That piece does not bleed more than if I had left the whole thing intact. No.
Oh, thank you.
You're welcome.
Thank you for the work you do, and I'm glad you work with Dr. Steinberg because he did my surgery. I have multiple CCMs in my spine. I had a laminectomy recision with Dr. Steinberg 6 years ago, and then I also have some in my frontal lobe, left corona, and things. What is the likelihood of bleeds for people who have both CCMs in their brain as well as in their spinal cord? Does that go up? Is there a different correlation if they have both, or?
Yeah, I cannot give you an exact number. We don't have enough, well, we know that familial forms bleed more often than sporadic ones, but that's just the law of numbers because there are multiple ones. I quote patients, and I don't know if I'm wrong or right, but I quote them the same rate for each lesion. I don't know what Gary has told you, but that's what I do.
Hi.
Hi.
Thank you for being here. My question is, at what point, and you touched on this, what point do you decide when to have surgery and when not to have surgery? And the reason I'm asking this is because a year ago, I had a bad seizure, which is when they discovered that I had a bleed, and that was in July. As the days went on, they kept finding I was having more seizures. They were finding more acute blood product, and it didn't seem like it was going to stop. So the surgeon that I saw, and it was in a very small area in Pennsylvania, said, I think the best course of action is to remove this. And I've been left with some deficits, but I've had family members come to me and say, did you make the right decision? I mean, maybe you shouldn't have had surgery. And I said, well, I think I was faced with the, two evils, and I had to pick the lesser of the two evils, because if the brain kept bleeding, it felt like I was going to make worse, create more havoc than if I had the resection done. So at what point do you decide which is the lesser of two evils?
Yeah, may I ask you, is your lesion removed completely as far as you know?
It is completely removed, and it was in an accessible area. It was in my left temporal lobe. I had a functional MRI done prior to the surgery to make sure that they were not touching any.
Speech area?
Right, correct.
You have some difficulty finding your words? Or?
I do. I'm still, it's gotten much better.
Good.
Right,
Yeah.
and the first thing they asked me when I woke up from surgery was, there was a series of questions, and when I was talking to my doctor, he said, I'm so glad to hear you talking. This is the best thing I've heard all day. And I said, you're probably the only one that's going to say that. But thank you.
Yeah, no, I obviously, I don't know your scans, but I don't second guess what your surgeon decided to do. You're young, you've got decades of life ahead of you. If you go back to that slide from that Delphi thing, you fit in one of those green boxes where most of us who do this would have recommended surgery. Because, again, if you do the math on these 2.5% per year, it's going to catch up with you at some point. And if I, as a surgeon, think I can cure you today when you're younger and healthier than later, and by the way, many other factors enter into it. You know, cavernomas, they don't just bleed like an aneurysm bleeds, burst. It's seeping, it's oozing blood all the time, and that on MRIs, this black ring is a hemosiderin ring. So it's seeping iron-containing blood, and that's so irritating to the brain. So now you let that sit there for a long time, you get two problems. You get the cavernoma itself that can bleed and cause problems. Then you can develop refractory seizures. So then the surgery becomes not just the problem of removing the cavernoma, but of curing you of seizures that could continue to occur even if the cavernoma is removed, the hemosiderin ring is not removed. So to do seizure surgery, most seizure surgeons remove brain along with the lesion. That complicates the whole thing. So I'm pretty sure your surgeon did the right thing and removed it, and I can barely detect any neurologic deficits with you right now. So.
Well, and that's one of the reasons that my family questioned, is because I still have seizures.
You do?
I do.
But are they controlled with medications, or?
We're getting there. They're mostly controlled.
Okay.
But I still feel like had the blood product continued to seep into my brain, since that bleed was not controlled, that it would have done worse.
I'm sure you're right. This is a classic debate among us neurosurgeons, lesionectomy versus lesionectomy plus, meaning you remove the lesion alone or lesion plus surrounding brain. And it really all depends on the details of your case, whether hopefully the medications will control it well, but if it doesn't and your seizures become more often, more frequent, you may need, and that's not my specialty because I'm not a seizure surgeon, but you may need, seizure mapping, electrocorticography to figure out if there is a safe way to remove the epileptogenic tissue. Hopefully that won't be necessary. But
And I have multiple lesions, so there's
you do?
Yeah, I do. So there's no
okay.
proof
that
that's
this is
the
lesion.
one. Exactly.
Yeah, that's right. Yeah, but good quality EEG can figure it out, which one is the source.
Thank you.
Hello.
Hello.
I'm Hannah Irby. I got my CM diagnosis at 2002 when I was 8. And that led to a stroke. I had another stroke 3 years ago. And right now, I'm dealing with partial sneezes, which is like no explosive, like achoo.
And you cannot control it. You cannot control it.
No, it happens almost every day. So I'm just wondering if you know what's causing that.
Do you know where is your cavernoma in your brain?
Oh, I'm sorry. In the middle of my brainstem.
Yeah. Well, that is the center of respiration, and therefore that's probably you're having what's called the phrenic nerve stimulating your diaphragm and making you sneeze. And you were told that it's inoperable, or?
No. Back then, they tried to get out as much as possible, but a little bit still remained. And I found out last year that my CM had grown 3 sizes. well, significantly bigger if it, my doctor's words.
Okay. Well, I'd have to look at your scan to see if I think what's left can be removed or not. That, I mean, if that's what's going on. You've had 2 events from 20 years ago and 3 years ago. But yes, I have patients with intractable hiccups too. Actually, 2 years ago, I remember him, he was getting on a plane. Anyway, he had it between the medulla right here and the pons. Well, it's not on this cut, but approximately right here. And he could not stop hiccuping, not sneezing, hiccuping. I took it out, completely disappeared, and he's doing fine. So it really all depends where your residual CM is.
Well, I did some research and found out that it's the medulla that's doing all the havoc on me.
That's right.
But I don't, you said that's right?
The medulla, yeah, that's where the respiratory center is, and the hiccuping center, and the nausea center, something called CTZ, chemotactic trigger zone. Nausea, many CM patients with medulla lesions complain of those things. Yeah.
Okay.
But I probably scared you by showing that slide. I said the medulla is the toughest one to operate on,
Yeah.
but that's true. But you never know if there is a path, and I don't know. I'll have to look at your scans.
Okay, one more quick question. How close is the brainstem to the medulla?
The medulla, I didn't make it clear. The brain stem is made out of 3 stories. Medulla is story first floor, pons is 2nd floor, midbrain is 3rd floor. All 3 together, we call the brain stem.
Okay, I didn't know that. Thank you.
Oh, sorry, it wasn't clear. I'm used to talking to my peers all the time, so sorry.
Hi, Dr. Morcos. Hi, I'm back here.
Hey, how are you?
First of all, thank you so much. This short presentation has been totally fascinating, and I just recently changed my care to your team at UM, and I'm very much at ease, so I'm
Great.
glad. I have a question. In a case maybe similar to the one you presented, of a small cavernoma close to the brainstem that has already bled, but without strong symptoms, or at least not strong enough to affect quality of life, daily quality of life. If a conservative approach is taken, are there any preventive measures, or what can a patient do, anything at all, to either avoid or delay the possibility of another hemorrhage? And you mentioned 5% per year, that the chances of hemorrhaging, again, on a brainstem cavernoma. Does that go down the longer a person goes without a second hemorrhage?
Yeah, excellent, very good questions. You reminded me, I skipped on a slide, something called, I want you to appreciate that concept, temporal clustering. Again, you'll find it in some of our papers. What does that mean? A patient has a hemorrhage today. That patient is more likely to hemorrhage close to the time of their current hemorrhage than later on. So the line is not linear. So we call it temporal clustering. So they're likely to have another hemorrhage, I don't know, a few weeks later. They're more likely to have that than a year later. So these numbers that we use are average number. I tell you why that's important. We can talk about that. You will find perhaps that some neurosurgeons treat some cavernomas with gamma knife or radiosurgery. I do gamma knife for tumors. Most of us who do this work do not believe a second that gamma knife has been proven to have an effect on cavernomas. Even the people in Sweden who invented the gamma knife themselves say that. So So the reason I say that is because when you then try to calculate and prove that, let's say, Gamma knife has decreased the rebleeding rate, the numbers are not clear. People forget that there is temporal clustering. So the Gamma knife results cannot take credit for the natural history. I don't know if I'm being clear, but it's a little complicated, but just to explain to you, in that third question you asked me, that there is temporal clustering. Patients are more likely to bleed and rebleed closer to their last bleed than in the remote future. I already forgot what you asked me first. What was your first question?
Hemorrhage. Is there anything she can do?
Oh, anything you can do. I am not, unless you guys heard something the last 2 days, I don't know of anything to tell my patients. Diet, exercise. It's not like aneurysms. Aneurysm, if you're a smoker and you're hypertensive, you're tripling your risk of aneurysm growth and rupture. Cavernoma, I mean, all we can tell is there is an inflammatory cascade, and whatever lifestyle is anti-inflammatory is probably better anyway for your general health. So that's all I can say.
Hi, I have a midbrain CCM tectal plate, and
Tactile plate, you said? Yeah.
and my understanding is that the lesions can fluctuate in size a bit. Mine over the last year has gotten a bit smaller, and I was just curious on how common that is.
Yeah, it's common because when you understand that it's not a tumor, it's caves of channels, we call them sinusoidal channels, with pretty much blood in them. So if there is some seepage during some period of time, it's like you bruise yourself. The blood will get reabsorbed partially. Then it might seep again. So if you scan yourself very frequently, you might see some seesaw pattern. It's okay. I wish I could say that means it's curing itself. No, but yeah, I know. But yeah, it's not uncommon. Even some tumors, that's another conversation, but some actual tumors can shrink spontaneously. Meningiomas can do that, acoustic neuromas can do that, so let alone cavernomas.
Is there a difference in the brain's ability to heal from a bleed versus surgery? Like, in other words, is it, I guess this may be a personal question, but is like doing surgery worse for like brain recovery than recovering from a bleed?
Yeah, no, it's a good question. I tell my patients, at least for the brainstem, I tell them, look, most of the time when I'm going to operate on you, it's going to feel to you like you've had another bleed. That probably partially answers what you're asking me, because I'm going to touch this area. It's like you've had a bleed, but hopefully, of course, you will recover from my surgery. Oh, well, my resident, Eva Wu, I don't know how many of you were in the audience, presented yesterday our results, and it showed a very nice graph of how the patient very likely will worsen from the surgery before they get better and they reach a stage better than what they started with. So there is some worsening to accept. And you see that in all the series. Doesn't matter. I mean, even the best hands. Spetzler, my mentor of decades ago, in his papers, 50% of the patients got worse with the surgery in the hands of a master. But I mean, some got better and so forth. So that's what I tell patients. You are going to be ready for it. You're going to feel like you've had a bleed. But if I get the cavernoma out and I cure you, it's going to be worth it.
My turn. So first off, you guys ask really good questions. I think you're appreciating that.
I'm
oh my
very
gosh.
impressed.
All right, so my question is, A lot of the folks in the room have multiple lesions because they have the familial form of the disease. And as you mentioned, the number of hemorrhages people have is usually proportional to the number of lesions they have. How does that change the decision-making for surgery? Is there a higher bar if someone has multiple lesions?
Yeah, Connie, it's a very good question. It's overwhelming when you have multiple lesions for a surgeon. Of course, none of us will look at the brain of a patient and, we will focus on the most active lesions. That's what I do, and the one that is most threatening to the patient. And it's a chronic illness, unless there is a way to remove them all, which most of the time there isn't, safely. I just focus on the larger one or the one that's changed the most over time, because that's clearly the one that is now biologically active. And I watch the others, and I have 2 sisters I've operated on. I don't have their slides today, but again, that's what I've done over maybe 15 years. They would grow one lesion, and for some other reason, her other lesion never changed in 15 years. I only had to deal with one lesion. So you can imagine if I had operated on the one that eventually never grew, I would have hurt her unnecessarily. Mike?
Hi.
Oh, sorry. Yeah, go ahead.
So I have the sporadic form. I have 3 clusters together in my thalamus.
You
I
said
have
three?
3 clusters together in my thalamus, so it's deep in the brain. I just wanted to know, like, I got a VP shunt, and I got it placed in 2015, and I Googled how, like, it could eventually stop working. I have to get it readjusted. Like, a year ago one time, it's on my right-hand side because it's affecting my left. So, like, it was popping out, like, on my ear. Like, I just want to know, like, does anyone else have a VP shunt? Or, like, how long you think it will last?
You're talking about the shunt.
Yeah,
When was it put in?
2015.
15. Do you know if it's a programmable valve?
It's a programmable shunt. I can't go through metal detectors.
Okay. Completely unpredictable. I tell patients having a shunt is like plumbing in your home. It could go on perfectly fine for 20 years. It could block the next year. I assume they put yours, you must have had what's called obstructive hydrocephalus.
Yeah.
Your cavernomas must be closing what's called the third ventricle. Again, I don't know your scan, but if your shunt were to fail, it's easy to revise, but there is an alternative to shunting. It's called an ETV. With an endoscope, we poke a hole in a certain area, the floor of the third ventricle, so you don't need a shunt. Assuming, I don't know if your cavernomas are in the way, but if they're not in the way, that's a nice way to not have to rely on a shunt. But it's working now, so I wouldn't worry much about it.
All right, and
Okay, I'm sorry. I'm just going to piggyback on what she was saying. One of my questions was, what was it? Sorry, it was there. It just left. It left. It'll come back to me. I'm sorry.
I think the yeah, okay.
Hi.
They're beating you.
Sorry.
Hi.
First of all, I want to say thank you for validating that you don't know everything. That's really it's a relief.
My wife reminds me of this every day. What are you saying?
I've had a lot of health issues in the last 15 years, and I've been to doctors who have pretended to know things and sent me down the wrong path. And so, on my own, I've researched and Googled and all this stuff, and I feel like I always come in really prepared. So it's just really nice to hear experts be like, we just don't know. It's very validating. So that's number one. And it ties into my question, because I've had so many issues, and now I've had this very unexpected CCM in the last 2 months. I'm wondering if some of those things have been related, and Billy asked this question yesterday to some of the being being with patients all the time, if you've noticed any sort of relation between having CCMs and having other types of autoimmune disorders.
Other what disorders?
Like autoimmune disorders, or specifically I had endometriosis, adenomyosis, PCOS, insulin resistance, a bunch of stuff.
I have not. I have not seen those correlations. You have one CCM?
Yeah, I had one. It was just removed 2 months ago.
Okay.
Yeah.
No, I cannot say that I can think of a link.
Okay, thank you.
Hi, doctor.
You better make it good. We waited so long for your question.
I got 2 questions for you. First of all, in your decision making, does that depend upon the equipment that you have in your OR and your skills? You know, if you don't have the skills and the equipment to get to a particular place in the brain, do you send someone to go to another hospital? And number 2, when does a headache turn into a seizure? You know, for my wife, when we found about hers, she had a leak and a bleed, but they said they could see dry blood on the scans before, well, 3 or 4 months before she had a really bad headache. So does that, when does the headache go to a seizure, so to speak, from the bleed? Yeah.
So your first question, particularly for cavernomas that are in a tough area, not every neurosurgeon should, certainly no neurosurgeon that's not subspecialized should be dealing with brainstem cavernomas. They're rare. The most expert among us have not operated more than a few hundreds in our entire career. I do 450 brain surgeries a year. I've been in practice 28 years. I've not done more than, and I'm considered one of, I do a lot of this stuff. So luckily, neurosurgeons who see a tough cavernoma really don't want to deal with it. They usually refer them, and that's how we get the patients. The equipment in the OR, the high-tech stuff isn't really that high-tech compared to other stuff we do in neurosurgery. What you need is monitoring, neurophysiologic monitoring, and you need a navigation system to be very accurate. The challenge with cavernoma is choosing the right path and opening just the minimum amount of brain tissue you need to open precisely. That's it. Once you're there, removing it is actually easy. It's easier step. Headaches, seizures, bleeding, they're all interrelated. It's certainly possible that, as I said, the hemorrhages are not usually explosive. They can be, particularly if they break through this black ring, the hemosiderin ring, then the patient will have significant deficits. That's the difference between what we call intralesional hemorrhage and extralesional hemorrhage. And yes, the blood will irritate the brain, you'll have seizures, so it's all kind of interrelated. Thank you. Yeah, it was a good question. It was worth waiting for.
Hi, I live in Florida. I missed part of the front of things, but I have a DBA all entangled in a CCM right at my parietal temporal occipital junction, and I've been having tachycardia and some neurological things that have started to present themselves just even recently, as much as yesterday, which is why I was late today. But my question is, I'm still at the point of getting some of this diagnosed. I'm currently at Mayo with a gamma knife junkie, and so I'm a little...
Mayo Rochester or Mayo Jacksonville?
Jacksonville. I live in Ponte Vedra. So I'm more of a conservative approach with everything anyway, but I'm a little concerned. Have you seen a lot of neurological effects and things? The ring has not formed yet. My hemorrhage happened around March. I had phantosmia. I think that's pronounced correct, but I was smelling smoke that wasn't present.
I'm sorry to interrupt you. Where is you said parieto-occipito-temporal, you mean here?
So it's right near the junction of
all 3 lobes?
Yes, and I know...
Which side?
Right.
Okay.
And I know somebody mentioned the insular area having something to do with regulation of heartbeat and things yesterday.
Yeah, not very common. So, I mean, if you
I'd love to be rare.
Yeah, exactly. I assume they should or have done a cardiac workup to make sure your tachycardia is not cardiac in origin. That's the first
That's
thing.
a brand new thing that just came yesterday. It was an
yesterday.
awesome surprise, yes, as I was driving down.
Well, weren't you just anxious? I mean.
No, I was bouncing from 150 to 70 to 150 to 70 all day. So it was really bizarre. And then an HRV hit 2 milliseconds. And so it was a little freaky, but I'm getting a 7 Tesla MRI that's coming up to kind of explore some of the vessels. And I just wonder, have you seen this junction? I know it's very rare, but since you've done so much.
No, what is very rare is a link with cardiac events. That's location isn't very rare. I just don't know how deep it is, how on the surface. Functional MRI will tell us where all the tracts are displaced. And it hemorrhaged once, you said.
We're assuming it's the cavernoma that hemorrhaged instead of the DVA, but the amount of blood that has been shown on the UF or 3, I think it's 2 Tesla MRIs, is showing some pressure on that vein in the middle.
Let me make sure I understand. There is blood, but they're not sure if it's a cavernoma.
Or the DVA because they're so
DVAs
close.
don't bleed.
That's what I heard, but I heard there's also rare cases that
I have one case, and I should have reported it many years ago, of a DVA that caused a stroke, a venous stroke. But that's one in 28 years. So if there is a DVA that so-called caused the problem, there must be a cavernoma attached to it.
There is.
That caused the. Well, but they have to wait till the blood goes away, repeat it, do they actually see that cavern? And they did, or we're waiting?
We're in that process. It's a fun process.
Yeah, no rush. No, let the blood, it's important, very critical to know.
Could you tell it to hurry up?
Okay, so we've been talking about the familiar form. I have sporadic, and do you have any information or any knowledge on the sporadic form, and how it came about?
Well, I mean, they're easier to handle because there's one, or you said you have 3.
I have 3 clustered together in the brain.
3 cavernomas very near each other.
In my thalamus, so it's in the center of my brain and it's not operated. I can't operate on it. And my doctor wouldn't want to operate on it.
And you saw a top expert in the field?
He was actually on the board, Dr. Colony, Sander Colony.
Sander at Columbia?
Yeah, because I'm from New York, so he was my surgeon.
Yeah, I'm going to see him tomorrow. I'll say hi to him. I'm flying to New York tomorrow. Okay.
And,
not all thalamic cavernomas are inoperable. There's a part of the thalamus called the pulvinar, and I don't know. Again, I'll have to look at your scan. I need to know where it is in relation to what's called the internal capsule. This is a tract that makes you move your arm and leg. That's on one side of the thalamus. But if the cavernomas are on the back part of the thalamus, they are definitely operable. There's a certain way to get to them from the back. So I don't know specifically yours. But sporadic is less likely to bleed than familial. That's all we know. And that's kind of better news for the sporadic cavernoma than the familial ones.
And what's the percentage of people that have it sporadic that's in the brain versus people that have it all over their body and it's familial? Because I read it's 4% people have it in the brain and spinal cord, and then the rest is...
If I take 100 people off the street, 0.5% will have a cavernoma somewhere. And 50% of the familial are multiple.
Okay, so I'll answer that one real fast. Sorry. So 75 to 80% of people who have a cavernous malformation have the sporadic form. So have just one or have a cluster that's typically around a DVA. And you didn't mention that you have a DVA, but that might be something to ask. And then, as Dr. Morcos said, about half of, we say 1 in 500 people have a cavernous malformation, mostly in the brain. I mean, that's what we're talking about. This is a brain disease. And I think that was what I was supposed to say, right? Is that the question?
It was, I think, versus the spinal cord, yeah.
Oh, and like, of the people who have cavernous malformations, about 15% or less are found in the spinal cord, and 85% or more are found in the brain. How many sporadics are multiple? Linda, one more time, sorry. Okay, we used to think 0, but then MRIs got better. And so when they're multiple, though, they're clustered. There's typically a DVA that precedes the cavernous malformations, and then there can be the development of more over time. And again, 7 Tesla people, you may be hearing things that you didn't hear when you had your 1.5 Tesla. Just.
By the way, which reminds me, if I can interject, DVA and cavernomas. This is kind of subtle. We don't want to injure the DVA as surgeons because you create a venous stroke. But if you think of the DVA as a trunk of a tree with branches, the cavernoma is sitting, whatever, like a piece of fruit on one of the branches. I was so careful early in my career to just prune the fruit and leave the branch. And I had 2 recurrences in the brainstem, of course. This stuff always happens in areas where you want to be super careful. And they both recurred on the same branch. So I went back in and took the branch, left the tree. So when I go around and I teach, whatever, I speak to others, I say, yes, we should save the DVA, but please take the branch. Oh, this thing. Can you see it from there? This white thing, it's a vein. It's a big vein. That's the way people who have it are born. It's an anomaly, developmental venous anomaly. They're born with a vein that shouldn't exist in this shape or position, and cavernomas sprout from one of their branches. Yeah.
I have another question. Hi, doctor. Thank you. So I just had a first bleeding 2 months ago, and then I had another MRI 3 weeks later, and I had a different bleeding. So I'm going to tell you the locations because I don't know. This is all new for me. One says it's at the corpus callosum, and the other one says it's at the thalamus ganglia.
What's the second? Thalamus?
Thalamus ganglia.
Yeah.
Are those brainstem?
Not the first one. The second one, it's debatable whether you count the thalamus and what's called the diencephalon brainstem, but it could be considered the second one, yes. So 2 separate locations there.
2 separate locations in 3 weeks.
And they both bled? You were told both hemorrhaged independently?
Yeah. So the first MRI, they only found one, just one.
Okay.
And 3 weeks later, they found the other one. And I had an MRI 10 years ago, and they didn't see anything.
But how do they know, particularly on the second MRI, since there is a hemorrhage, do they actually see a cavernoma with that hemorrhage? Very unlikely.
They haven't even told me that this is a cavernoma, so this is,
that's
so recent. They don't know. I haven't had.
How do you feel now? You have any?
I only had a headache. Okay. Vision changed a little bit, and I'm having like joint pain in this wrist, a little bit of numbness on this arm.
Well,
that's it.
It'll be highly unlikely that the cavernoma develops in 3 weeks. I mean, it's that, even if they look back in retrospect, they couldn't find it, correct, on the first MRI?
That's what they said, that they couldn't find it.
I wouldn't jump right now to the conclusion that you have cavernomas. Sounds like, I mean, again, unless I can't see the scans, but wait till the blood, usually we wait till the blood dissipates, like the earlier patient who's asked me. Repeat the MRI, see if all has cleared. Have you had a DSA angiogram?
I had an angiogram last week. I had a lumbar puncture last week, and everything went well.
The angiogram is normal, and you don't have a DVA, not only looking for AVMs or, okay.
I don't have anything.
I don't know. Your case isn't like classic, so I don't know. The devil is in the details.
Okay. Can I make an appointment with you?
Anytime.
We live here in Florida, in Tampa, so we're very close.
You're in Tampa?
Yes.
Yeah, I'm here.
Okay.
Yeah.
Do you know Dr. Agassi? He's the one who saw
Dr. who?
Agassi.
Severo
Severo.
Agassi. Yeah. He has even a heavier accent than me. He's Swiss.
Yeah.
Yeah, I know him well. Swiss Italian.
So I have another MRI.
No, he's a good, excellent,
in 6
excellent.
weeks, and an appointment with him. But I would love to see you too.
Sure. Tell him I'm watching him if he's going to screw up with you. Anytime, no problem.
Thank
you. I just wanted to make a quick comment about how you had mentioned the gamma knife.
Yes.
We did do that with Hannah. And I can attest that she did have a rebleed.
She did have.
She did.
Yeah. No, and oh, sorry, go ahead.
No, and I was going to say that probably if we had more information at the time, because it was back in 2002 when she had the surgery in the brainstem, and it was in the pods, and it was basically desperate parents. I'm just going to say.
No, of course.
And it was recommended. I mean, we did research that we had at the time, but I think it maybe bought time, but she's had 3 rebleeds, so I really can say that I don't think it did anything.
And if you ask...
And it was
go ahead.
More nerve-wracking than the brain surgery.
The gamma knife?
It was.
Yeah. Even if you ask the very thoughtful neurosurgeons who do gamma knife, one comes to mind, Doug Gonziolka, who's superb and one of the best. He himself, when he talks, he says, look, if a patient with CM comes to me and tells me, and all the best surgeons tell that patient, you're inoperable and she keeps bleeding, I'm going to try gamma knife. If I can do it safely. So it's not incredibly wrong to do it, but it's wrong to tell the patient and families that we have data that shows that, hey, this helped. You know, that's, I absolutely shouldn't, don't blame yourself at all. But many of us surgeons do it, so let alone families, you know.
Yeah, but it was, you know, like the surgeon that she has now said, you know, it's, you know, would have it still bled, but it still did 3 times later. So, you know, he said maybe it botched time, but, you know, he said I would have definitely, like you just said, not recommended it.
Yeah.
And that happened 10 years, well, when I was 26, that happened 10 years before that, the gamma knife. And so I was wondering if the gamma knife kept me from having a bleed 10 years, for 10 years.
Hello. What was that saying?
Yeah, if the gamma knife kept you from having a bleed for 10 years, it goes back to what I was saying earlier, temporal clustering. It appears that way. That's why it's easy, it's been easy for many years for people who do gamma knife to say, look, the patient bled 3 times in 2 months. We did gamma knife. She's gone on for several years with no bleed. But that also is often the natural history of cavernoma because of this peak of bleeding after the first bleed.
Okay, I'm sorry, but can you repeat that?
How am I going to explain it differently? So, bottom line, we don't know if the gamma knife really stopped you from bleeding for 10 years. That could have been the way your cavernoma was going to behave anyway. But now that's the past, really. What can we do about it?
Okay, and what? Oh, no, go ahead. And in high school, I think I had a third ventricle endoscopic whatever.
ETV,
Yeah.
yes.
Yeah.
So you never
And-
needed a shunt,
No.
I did what you said exactly.
right?
Yeah, but you implied that they don't do that anymore?
No. On the contrary, I was answering the patient there who has a shunt. She was worried her shunt would get blocked. I said,
Yeah.
if it gets blocked, it can be fixed. But if somehow the shunt is causing more problems, she could have what you had, which is an ETV, poking a hole. It's like diverting traffic to a different area without leaving hardware in the brain.
Oh, okay. Thank you.
Hi, doctor.
Hi.
So you actually operated on me. Yes.
Hello, you were hiding here.
I was hiding. So you have seen my scans. My question to you is more of like after surgery, what are the common side effects that I should be feeling still? Because I still do get numbness.
Which part? Tell them which part of your body.
Oh, I have parietal. I can't say that parietal lobe.
Yeah.
It was on the top, and I still have my brainstem one that you did not want to touch.
Yes.
But the parietal lobe, that was. Thank you for everything. The scar doesn't show at all, so thank you for that.
I haven't paid her anything.
No. Just my life. No.
There you go.
But it was definitely, I felt at ease with you, so that's why I chose you, and I continue to go with you. But it was more of, so what are the side effects? I'm still receiving numbness and random weakness on my legs. Like, I lose my balance. I do get double vision sometimes, but now that someone mentioned the throat, swallowing has become an issue for me. Like, I feel it in the back at least. And then somebody mentioned yesterday about breathing and sleeping. I'm like, I should go get a sleep apnea machine.
You know, that stuff, this auto-suggestion can be so dangerous. You know? We're all guilty of it. We overanalyze what we go through. In your case, as you well know, you've got this large pontine cavernoma. And look at you, you're perfectly functional. I know I will hurt you if I operate on you, which is why I'm waiting to hopefully never have to do anything for you, but I need, going back to this graph, I mean, decision-making is always, it's an equation. Okay, well, what is the patient going through? What can the surgeon offer? When it tilts in favor of the surgery, that's when I'm going to do it. And you're nowhere there. It needs to, as I told you in the office, needs to grow more, reach more a surface, because as you know, it's in the middle of the ponds. There's no surgeon in the world that's going to get this out now and leave you happy. You will be so miserable if I removed it now. You'll be probably devastated. Now, and I think many of your symptoms are due to that, but they're transient. That's why I'm sitting doing nothing about it. Some of your sensory function complaints of the other side of the body are due to the parietal one that I removed. That's where the sensory fibers, but again, they're not that bad, correct? I mean, they're just on and off.
But
yeah.
It's more like, it's been almost a year in October, so should I continue waiting or just manage it until it becomes unmanageable?
What is there? I don't know that we can do a lot about it. What can we do about it? No. Distraction. What's that?
Find the winning lotto numbers. That's what
There you go. Oh,
Hi.
go ahead.
This is with respect to CCM and his kid's age. My daughter had a pontine cavernoma removed 10 years ago when she was 4 years old. Dan Barrow at Emory did it. We keep a real close eye on her, as does he, with MRIs every other year. She has 8 or more scattered around her brain. She's had scoliosis. She's had the surgery for that. She's a little teeny bit symptomatic, whether that's residual from the surgery or not, I don't know. A little imbalance, a little cognitive with math and whatnot. But as I read more about CCM3, it seems as if when it develops in children, if I'm interpreting what I'm reading correctly, that the severe symptoms wane as they get older. She has not had another event that we know of. It has just been progressing after the surgery and improving and, growing up. What does it look? What does that, statistically speaking, that picture look like as she ages? Are we going to likely continue dealing with improving on her deficits and compensating for them, and they are fairly minor? Or are we bracing ourselves for, another event? I'm encouraged by what I read on the Alliance to Cure side about the symptoms kind of dissipating a bit with age.
Yeah, the other several lesions have not grown in 10 years.
There is one that we're watching. She has another MRI scheduled in, I think, 2 months. One is at 8 millimeters. It's grown from 5 to 8 in, 5 or 6 years.
Yeah.
And Dr. Barra wants to keep an eye on that and see where that goes. So we'll know a little bit more.
Yeah, I unless Connie knows more, I don't do pediatric neurosurgery myself. I don't operate on children unless they have some so I don't know the statistics of transition from childhood to adult life. But I don't know if Connie, you have anything. Would you like to say something about that? I don't know data on that.
Melinda and I talk all the time.
Oh, okay, all right.
Yeah, no, but show of hands, I just want Dr. Morcos to see the CCM3 families that are here. Raise your hands. Go ahead. I know you're all here. One more in the front here. So it's a different beast, and we know this. We know that with CCM3, you're much more likely, 50% of the folks that have hemorrhages start hemorrhaging as children. That particular group does tend to slow down, and the lesion proliferation also tends to slow down. So in the beginning, we're seeing lots of new lesions. It's not unusual for a 5-year-old to have 25 or more lesions in their brain. That slows down over time. So, I think there's reassurance for those of us who started with littles having their first surgeries and having their first hemorrhages, that adulthood will look different. There will be deficits. And I think for everyone, there are deficits, and they're not necessarily going to get better, but that doesn't mean it's going to get worse. Now, that said, the folks who escaped the worst of CCM3 in childhood, that does not mean that they are free and clear. I think what we tend to see is if you did escape it as a child, there is probably a higher chance that you're going to see something more in adulthood, and that is anecdotal, my impression. I know all the CCM3 patients pretty much in the world that have come forward, and that's just sort of what we're seeing, and Dr. Awad can help track that as well. So.
Great.
We're getting near time, so just a few more questions, okay?
Can you hear me? Okay. So I have a question for you about MRIs. Can you explain what types of MRIs? Because I've heard people talk about all different kinds of MRIs. I don't know what MRIs I had. I went into the hospital on a Friday, had brain surgery on Monday. It was very fast. So can you explain what types of MRIs we should be getting after surgery or even maybe throughout?
So I don't like to give gadolinium unnecessarily in general patients. I usually get one time only gadolinium to see the DVA. You cannot see the DVA well without GAD. So I need to know, does this patient have a DVA that I need to chase? Let's say I do surgery. Once I know, I repeat MRIs without gadolinium for follow-up, and I usually ask, it's either called, that's my preference, a Fiesta or a KISS, C-I-S-S, depending if it's which machine it is. These are very thin cuts through the areas to capture a recurrence of a cavernoma or a de novo one. That's what I order, a thin cut KISS sequence, I call it.
So when people talk about Tesla 7, what does that mean?
Yeah, it's rare to be able to access a 7 you heard earlier. So most MRIs we do, it's the strength of the magnet. Most MRIs used today are 3 Tesla, and that's That's a 3 Tesla, for example. 7 Teslas are rare, and they take a long time, and I'm not sure the benefit of in cavernomas. Even if you knew there was a tiny one, we're not going to operate on one when we see one. 3 Tesla is going to pick up the relevant cavernomas that are going to show up. I've done many years ago, actually 20 years ago in the lab, we did 7 Tesla back then. Took 24 hours, 20 years ago, on actually specimens, on cadaveric specimens of the brainstem. It's beautiful images. It's like you won't know the difference between cutting the brainstem, looking at it, and the 7 Tesla. But it's clinically not particularly relevant today.
So these MRIs that you mentioned, the KISS and the Fiesta, are those like easy for us to? Well,
Very easy.
if I go to Jackson, you guys will have it there.
No, actually, any hospital, yeah, the neurosurgeon has to order, please obtain KISS, CISS sequences, and the area I'm interested in.
Okay, thank you.
Sorry, one more. And then I think I probably can answer your question.
Just on the same lines as the MRI, I want to continue. Rachel basically had a Pons brainstem surgery that they missed and took them 3 times in 3 months.
3 surgeries?
3 brain surgeries in 3 months, twice through the side and the last one through the back. And she has a hearing implant that we were told is MRI safe. And now it is safe, it can go through the machine, but it casts a shadow, so they can't actually see the surgical site. And our doctors say it really is gonna just go based on symptoms. So how important is it to really look at that site, or we're just gonna go on symptoms anyway?
Even a CT scan is casting a shadow on, because sometimes...
They can see through the CT scan.
That's good enough. Thin cut CT scan would show you if the cavernoma, is there a residual cavernoma, or we don't know?
We don't know, we don't know.
CT scan and symptoms together is probably good enough anyway. I mean, if they've had difficulty 3 times surgery, the bar to reoperate on her is going to be incredibly high. So, that's, I mean, what else is there to do? We'll just watch it that way.
Okay, because we didn't know, should we get the implant removed, like, you know?
No, if it's helping, I wouldn't mess with it. If she's stable symptom-wise, I would stay with that. Yeah.
Okay, thank you. Okay. I'm going to run up for a last question.
Hi, thank you for your time here. You mentioned before that sometimes cavernoma are attached to a DVA. So in your experience, how often it could be possible to attach to a AVM? Or there are 2 different
totally different
chapters
diseases.
of the...
Never seen it. AVMs is a completely different disease from cavernomas. AVM is arteriovenous malformation.
Exactly.
Arteries, veins coming together, not associated with cavernomas at all.
You never seen something
Never
like
seen it.
Like my daughter. Okay.
Your daughter has a cavernoma and an AVM together as one lesion?
2 different surgeries, 5 years apart.
Does she have a certain genetic syndrome, or did they do genetics on her?
Well, we never take genetic
Counseling?
No.
Yeah.
There's no relation
not
at all.
I've never seen it. I've not. Yeah, I have not.
All right, we're going to end questions here. Thank you. I want to thank Dr. Morcos. Oh my gosh, this has been amazing. We have
Thank you.
learned. And I also want to congratulate you on just asking really phenomenal questions.
That
I
was
think.
phenomenal. Yeah, I agree.
And so we have, I don't know if you're aware of this, but you can recommend this to some of your patients who may not be here. We have a patient expert course. It's online. It's 5 hours of videos from past conferences and readings, and they have quizzes that they have to take. And I just have a sense that there's a lot of people in this room that have been through the patient expert course because you ask such good questions.
I did not know that, so
Yes,
I'm
so
gonna
send
do
them to
that.
us, and by the time they're done, they're like as smart as any neurologist that you know. I swear. Not the surgeons necessarily, but they could start writing prescriptions by the time they're done with the course. So thank you very much. We look forward to working with you. We love that you have a center of excellence at the University of Miami, and anybody in this room, if your insurance allows, can go down to Miami and see Dr. Morcos or Dr. Stark, who's also there. And soon, Dr. Abla will be visiting.
Next month.
Will be there. He was the medical director at UCSF and is now moving to Miami.